I think it's important that looking back 10 years ago and now that the treatment of colorectal cancer, especially metastatic colorectal cancer, is becoming much more complex because we have more options to treat our patients, and this results in a better outcome. And we moved from an acute killing disease towards more and more chronic disease like breast cancer. And in that view, the study that was presented by Dr. Van is a very important one because you have different targeted therapies available, and the question is, what is the best one to be used in the front line in our patients with metastatic colorectal cancer? For the moment, yes, but there is one remark. As you know, when we use EGFR inhibitors in our patients with a new knowledge on the RAS mutations, I think we have to refine the group that is really having a benefit. And the test in the Van study was based on the KRAS mutation status and not on the extended RAS. So
Right.
there might be an impact on further analysis on the outcome of the study. I think first of all, if you have a patient with metastatic colorectal cancer, you need to divide on the clinical presentation. Is this a patient that is resectable, yes or no? That's an important issue. Is this a patient that we wanted to treat in a palliative setting? And is this an aggressive disease, yes or no? So the clinical presentation is important to make the first decision. A second point is we have one biomarker available, that is KRAS. With the new knowledge, this will be RAS. For example, in Europe, we are doing already RAS. And based on that, we make a second choice based on whether this tumor has a RAS mutation, yes or no. If this is a wild type, then we can choose between bevacizumab or an EGFR inhibitor. If it is a mutated tumor, there is no place for EGFR inhibitors. Depending on the situation where you are, for example, if testing can be done very it's a question of reimbursement. Not every country have the same reimbursement system for these drugs. What is better, bevacizumab versus an EGFR inhibitor? And then you have to see the whole strategy of your patients. Because if you start with a VEGF inhibitor, probably it's better to continue over the different lines with a VEGF inhibition, because we know that when you stop the treatment, you have a relapse and a rebound effect. There is an impression that there might be some difference in response in comparison with the VEGF inhibitors, and there is in some countries a tendency in patients where you want to give induction therapy to favor EGFR inhibitors over VEGF in these specific populations. So you can make a choice on certain factors, but it's still not clear what is the best strategy. It's depending on the presentation of the patient. If I have a patient currently with a possibility to go to resection, in that patient, probably I would use an anti-EGFR in combination with chemotherapy, although there are some conflicting data in literature for the moment. If I have a patient that I want to treat in a metastatic setting and palliate the patient, and there is no risk factor to use an anti-VEGF treatment, probably I would go for anti-VEGF in that situation. That's another important question. Currently, I don't think there is a difference between what is the best chemo backbone to start with. Either oxaliplatin or irinotecan are good. We know from an old French study that when you start with one and continue with another in second line, the outcome is the same whatever you start. So for me, there is no real difference between both. I think it's not only the study of Dr. Van Hoek that is supporting the fact that we progressed enormously in the survival of our patients. What I said in the beginning of this interview is that the complexity is there, We have different choice. We not only have systemic treatment, but also organ-directed treatment. And it's a question now to refine the puzzle and to try to have the right drug at the right place in the right patient. If you look in the individual patient in expertise centers, there are some patients that are surviving with all the options that we have available, including at certain point surgery in the evolution of the metastatic disease. You see patients surviving over 5 years with the diagnosis of metastatic disease as the starting point of the story. For the moment, I think you have the choice either to start with a VEGF inhibitor as a targeted therapy or an anti-EGFR, and it's depending on the presentation of your patient, the clinical situation where the patient is, what you favor, and what is the strategy over time in that given patient. So it's an individualized decision.